Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. In this programme we take a look at toxicology, but before we begin, here's a quick word from Rural Health West CEO Belinda Bailey.
Hi everyone. With summer and the end of the year fast approaching, I thought I'd just take this opportunity to remind you all of the Rural Health West locum services. We really understand how important it is for rural doctors to get a break and to book in advance with our locum service to get that break. If you don't get out of your town and out of your region every now and then, we know that it puts extra pressure on you, your family needs a break. We really appreciate that to keep you out there in the long term, you actually need to take holidays and you need to take time off to do continuing professional development. That's what our locum service delivers for you. Our locum service is called the Bush Locum Service or the Bush Buddies Service, and both services are available to rural GPs, private practice GPs anywhere in rural Western Australia. The program offers a range of financial incentives, but most importantly what it offers is a personalised, case-by-case service for you and for the other doctors in your practice. So at the end of the year fast approaching, why not give Joe or Courtney a call here at Rural Health West, and they'll make sure we do everything we possibly can to try and find a locum for your practice. So with that, I hope that the end of the year brings you lots of wonderful things and that you and your family have a fantastic Christmas, and that we'll no doubt get to see you sometime in 2012.
Thanks, Belinda. Well, our main discussion in today's programme is with Professor Frank Daly from the West Australian Poisons Information Centre. Professor Daly is an emergency physician and senior lecturer in clinical toxicology at UWA, as well as being the executive clinical lead of the Health System Improvement Unit for the Health Department of Western Australia. Frank Daly is with Olga Ward.
Frank, welcome to the program.
Thanks.
What are the common things that children ingest that actually do cause problems?
Not many things, surprisingly. The vast majority of paediatric exposures are accidental, small doses, and actually don't cause any problems at all. And that's really the footing to start the conversation on, because a lot of people get very panicky about all these household products and pharmaceuticals that they might get small doses of. But it's actually very uncommon for us to get really concerned about a child, even less common to require them to be transferred to a major hospital or undergo any major interventions. Having said that, there probably are about half a dozen things that if a child even gets 1, 2 or 3 tablets, it's possible they might run into strife, and we would want to know about those things early. So those things are the opiates, and unfortunately, somewhere in Australia every year or so, a young child will die after an accidental opiate ingestion. And that might be some methadone or some MS-Contin or something like that. But that can cause a delayed onset of respiratory problems and a respiratory arrest afterwards. So that's a real one to look out for. Another one is the tricyclic antidepressants. They're still relatively common out there, and it's possible after a dose or 2 of those to get central nervous system depression and cardiovascular instability and seizures in children. So that's something that we would want to hear about. Another one, which is relatively common these days, is the sulfonylurea diabetic agents, the oral hypoglycemic agents. And they can cause delayed and profound hypoglycemia. And often, it's a diabetic tablet and people aren't too worried about that. But that's something that they do need to be monitored for, sometimes even overnight with their blood sugars, or watch them and make sure they're okay in a hospital environment. Uncommon these days, but theophylline, a few large aminophylline tablets can cause children to be profoundly unwell, vomiting, seizures, cardiovascular instability, and some of the older anti-malarial tablets like chloroquine or the anti-inflammatory hydroxychloroquine can cause things.
Plaquenil.
Plaquenil. Things like, they actually act very much like the tricyclic antidepressants.
Now you said tricyclics. What about the antipsychotics? Do they give you the same kind of profound effects in kiddies?
Not so much. The ingestion of the antipsychotic medications sometimes causes some mild central nervous system depression or very mild drowsiness, or even the child to become a little bit spacey or anticholinergic. The thing that's really alarming about those medications is not what happens in the first 6 or 8 hours, but quite often kids get dystonic reactions sometimes even a day or two down the track. After a relatively small dose of those medications, if we're confident they haven't taken a lot, we might actually recommend that they be observed at home, but just tell the parents that they might have some bizarre movements, or if anything worrying happens a day or two later, they can come and see a doctor to get some assistance with that. Other tablets, another group of tablets which we do get concerned about in relatively small doses with kids are the cardiotropic medications, specifically the calcium channel blockers, which can cause bradycardia, heart blocks and cardiovascular collapse, even with a couple of tablets.
Yeah.
And
Beta blockers not so much?
Beta blockers not so much, with one important exception, and that's propranolol. And surprisingly, propranolol doesn't cause, in kids or adults in overdose, what we might expect with beta blockade, with low heart rate and cardiovascular collapse. They actually act more like tricyclics and can cause CNS depression and seizures and cardiac dysrhythmias, and sometimes in kids also some relative hypoglycemia. So it's a little bit of one out of left field.
Yeah.
But that's the list. People sometimes are surprised that 1 or 2 or 3 tablets of other agents don't cause problems. So it's actually quite hard for a child to ingest a very toxic dose of iron in an accidental exposure. You need 6 or 8 tablets in a toddler to cause any major effects with iron. Colchicine, probably need 10 tablets. Paracetamol, you need quite a lot of paracetamol in a single acute ingestion to cause a problem. The other one that doesn't cause too much of a problem, we get a lot of angst about, is the rodenticides, the rat poison, the Coumadin or the anticoagulants. In fact, if we're confident that it's a single ingestion, just once, we don't follow the kids up at all or do INRs or give them vitamin K. It's a non-toxic ingestion if taken once.
Okay, now you're talking even those rat blocks that they love to nibble on?
Up to a packet.
Gosh.
If ingested once. In fact, the rats, to get poisoned and to die, have to go back to it and eat it repetitively to be anticoagulated and to run into problems. So after a single ingestion, accidental ingestion in a child, we don't do anything. We're reassured, unless we have a suspicion that the child's been eating it repetitively. I remember a case once where we did have a problem with a kid needing vitamin K for a while, a month or two, because they'd built a cubby and were feeding it to the dolls and feeding it to themselves over a week or two. A little toddler. But a single ingestion, we're not concerned.
Now, a large number of my granny patients get young 7-year-old Jimmy to get through the childproof lid of their tablets because they can't get the jolly thing off. How childproof is childproof?
Well, look, it's an interesting point because I think everyone marvels at how some ingenious kids can get into these containers. Having said that, they've made an enormous difference in the last 50 years in reducing the mortality from poisoning. Toxicology as a specialty actually started in Europe and North America, focused on preventing childhood poisoning. In the 40s and 50s, there was actually quite high mortality from poisoning in kids related to lots of tablets and household products. Because back then there weren't childproof containers, there was very lax rules around where you could put poisons and household products, and kids died of their accidental ingestions. Now, because our medications are much safer, but we've also got these regulations, very strict regulations about how to store things, that has really passed. And now medications are much, much, much safer and more difficult to access, and most of our exposures are relatively trivial. Having said that, if you put some chemicals in the wrong containers and you put your herbicides or your pesticides in Coke bottles in the fridge, or if you decant your medications into more easily accessible containers, or you use dosette boxes, there's still an opportunity there, and we need to be careful about that. But most containers do the job of preventing toddlers or kids under 3 or 4 from getting large doses of dangerous medications.
On the bottles of things, you know, the ammonia cleaners and
Yeah.
whatever, they often say, you know, used to say if ingested, give milk or give charcoal or induce vomiting or whatever. Are there any rules of thumb that you could kind of go through for those kinds of household things?
Most of the routine household cleaners, like the bench cleaners and the things you spray on surfaces, the more dilute sodium hypochlorite cleaners,
Yeah.
are relatively non-toxic if there's a single sip or taste. And again, children will spit them out and be fine, and we would watch those kids at home, and we wouldn't use milk, and we wouldn't vomit or anything like that.
Yep.
The really dangerous ones are the things that we use like drain cleaners, sodium hydroxide based cleaners,
Yep.
or the particulate things that we use in dishwashers. The dishwasher, those very, very alkaline things, they're very, very dangerous. They definitely should be somewhere where the kids can't get at them. There's little evidence that giving milk actually makes much difference.
Yep.
And in fact, if you give milk, there's a chance if you give too much, you might make the child vomit again. And we don't want that to happen. So inducing vomiting again is something we don't do anymore because you'll just re-injure the area as it comes back up again. So dilution, either with water or milk, we don't really strenuously advise anymore because it probably doesn't make much difference, and we don't want to endanger the child by possibly having another vomit. And we don't use charcoal at all anymore for corrosive or caustic ingestions because for two reasons. We're not really concerned about absorption and whole of body poisoning. We're worried about the contact poisoning or the contact injury, and charcoal doesn't prevent that. The injury is going to occur as the agent washes down the gastrointestinal tract and sort of cause an instant problem. So that's charcoal won't prevent that. Moreover, charcoal makes kids vomit sometimes. We don't want that. And lastly, if we're really concerned about a child and we think they need an endoscope at some point in the first 24 hours, if you've given them charcoal, when you look down, it's all black and you can't see a thing. So we don't advise charcoal. The most important thing, as with any poisoning, is the risk assessment and identifying those children that you're not worried about, and you can reassure everybody and not do too much, if anything.
Yeah.
Conversely, in a very small proportion of children, you can identify, yep, they might have a problem, and getting them to some sort of appropriate observation or definitive care as quickly as you possibly can without doing something that might actually cause an adverse outcome.
Yeah. And if you're in the country, obviously, and several hours from help, ring for help.
Yeah, look, we're really lucky in Australasia, and I say that because in New Zealand there's a very robust and easily accessible poison centre system as well. But in Australia, in every state and territory, if you ring 131126, you get put to a poison centre. There are centres in Queensland, New South Wales, Western Australia and Victoria, but after hours they all go to the same place, and you can get some initial risk assessment help, so you can find out what's in this product. Is it something I should be worried about? They get nearly 100,000 calls a year just about kids, and in the vast majority of cases, nearly 90% of cases, they recommend you don't do anything and you keep the kid at home.
And it sounds like that would be a good time to have a look at the Poisons Information Centre in Western Australia.
Look, there's nothing in it that's going to cause poisoning, but it can be quite irritating, yeah. If they've ingested quite a lot of it, it could be quite significantly irritating. So just make sure the mouth has been rinsed out. And if there's any persistent symptoms, any excessive drooling or vomiting or refusal to drink fluids or eat food, then just take them off to the local hospital, but it's probably unlikely. Yeah.
The Poison Centre is based at Charles Gardner Hospital, which is one of the big metropolitan hospitals in Perth. And we provide a service for the whole of Western Australia and also for the Northern Territories and South Australia. And any call that comes through from a member of the public or from a medical practitioner or a nurse anywhere in the state will get assessed initially by the poison specialists, who are usually pharmacy-trained specialists who've spent many years developing their skills and assessing and making a risk assessment for people exposed to either household poisons or pharmaceuticals or industrial chemicals. A lot of those calls can be dealt with very easily by the trained poison specialists, and up to about 95% of paediatric exposures, for example, will be told to stay at home. There's no risk that requires someone to be brought to hospital to be assessed.
Poisons Information Centre can help you.
The phone is answered by one of the Poisons Information Centre specialists straight away. They're not relayed through any process of selection. When the phone is answered, it's answered by the Poisons Information Centre specialist. Most are pharmacists by training and by qualification, but we have specific on-the-job training in poisons information itself, which is quite comprehensive.
So that's a very good filtering mechanism. But we also provide a medical backup. So I'm one of the clinical toxicologists employed by the Poison Centre, and there's myself and 2 other consultant colleagues who are both emergency or all emergency trainees, emergency consultants who provide medical advice, usually to medical practitioners or nursing practitioners who have patients that need medical treatment to be stabilised or transferred to a larger institution for definitive care.
Are you calling from the hospital or from the health centre? How old is the patient?
The good thing is we're linked in across the National Poisons Network, so there are a number of poison centres across the country. There's one in Sydney, which is one of the larger ones. There's one in Brisbane and one in Victoria and Melbourne. And together we provide a network that provides 24/7 cover. So at any time of day or night, anyone can phone up and get advice, be it, again, a member of the public or a medical person, to find out what the best management options are and also to help coordinate ongoing treatment for the patients. And it's very reassuring when you've seen enough cases, as the consultants here will have, you can pattern recognise what's going to happen. The good thing about toxicology is that you can predict what's going to happen in most cases. And when you've seen enough of those cases, you can give definitive, confident advice that allows the practitioner at the either the rural location or wherever they are to be much more confident themselves about how to deal with the case, what to look out for, and when they can confidently say that the patient is well enough to be discharged.
And do you have the bottle there with you? Okay. Could you give me some specific information about what it says? If the person's been exposed to a household chemical of some type, such as bleach or detergent or disinfectant, we have a very comprehensive database which we can access to look up the product, see what its ingredients are, check on the likelihood of it being irritant, corrosive, or just perfectly harmless. So we need the name of the product as accurately as possible. So when a person goes to the phone to ring the Poison Centre, we advise them to bring the container of the product with them to the phone. It's a little bit acidic, this one, but it's not likely to be very harmful. It's more likely to be irritant. So as long as he's had it washed off his skin, rinsed out of his mouth, then what you need to do is give him a small drink. And it can be milk or water, it doesn't really matter. Just some small sips, and make sure he's tolerating that okay. And if everything's fine with him, there's no need to be concerned. But if he does develop any symptoms that you're concerned about, give us a call back.
The good thing is we have a very close network across the country. We have regular meetings, and we are up to date with all the current toxicological literature, and we present difficult or interesting cases to each other at these meetings. We email the cases around to each other and get feedback from everyone pretty much within a 24-hour time period. So there's always an ongoing learning process, and it's very important that we get the calls from people out in the community, because we then realise what the pattern or the epidemiology of the poisonings are. Every year new formulations of drugs are put out or new drugs are released into the market, and we find over the years that many of those drugs have unexpected side effects or unexpected toxicological effects. And the information we gather through the Poison Centre from these calls allows us to write up cases or make journal articles that will increase the font of toxicological knowledge, both here nationally and also internationally. Any kind of thing, any kind of biting, stinging insect, We love getting snake calls. We are very excited in doing research into the snake bites or envenomings that we get in Australia. And it's purely through the setup with the Poisons Network that allows us to gather information about these cases. And that information is used then to make world-class medical literature about the pattern of snake envenomings and how to treat them to the best possible degree of competency. Similarly, any kind of drug exposure, we're happy to give advice. As I said before, the poison specialists are often quite able to deal with a lot of the phone calls and just give reassuring advice or provide a management plan without having to put calls through for definitive medical advice. But again, we're very happy to discuss cases with anyone, be it a rural practitioner, be it the head of the biggest intensive care unit in the state, anyone.
If anyone is in any doubt as to whether they should call the Poisons Information Centre, the answer is call. It's definitely always worth checking with us and putting your mind at ease or getting expert help when it's needed.
So Frank, we talked about children and we've looked at the Poisons Info Centre. Older kids and younger teens, of course, often get into experimental drugs and volatile solvents and paint and glue sniffing. How do these cause their effects in the sort of short and the long term?
Well, it's a big topic. As we've alluded to, most paediatric exposures under the age of 6 are accidental, and the peak age there is 12 to 36 months.
Yep.
But once you get into the more teens, you've got a more adult spectrum of poisoning.
Yep.
So we do start to see deliberate self-poisoning around depression and anxiety and those sort of things around the teenage kids, and certainly at Princess Margaret they deal with deliberate self-poisoning, and the spectrum of medications that are taken there very much mimics the spectrum of things taken in young adults that we see in an adult hospital. But we also start to see experimentation and abuse of substances, and really the thing that we see most is alcohol, to be honest, and we do see alcohol intoxication in young people, and that can be quite frightening for everybody. And certainly in naive users, suddenly getting drunk can cause quite profound central nervous system depression, and they can sometimes need quite careful supportive care. I think sometimes we can underestimate how drunk and how dangerous a severe alcohol intoxication can be in a kid. The solvents really act like anaesthetic agents. They're usually inhaled,
Yep.
and they go very rapidly into the bloodstream and very rapidly across the central nervous system.
So if you happen to get a kid brought in that kind of state, really what they're looking for then is respiratory support?
Well, often they get a mild euphoric effect, but then after that, they can get central nervous system depression and they can get seizures. And if they use a lot, if you get, especially with toluene,
Yep.
then you can get an interesting metabolic abnormality as well, with a metabolic acidosis related to a renal tubular acidosis. So if you have someone who's a habitual user, they can sometimes get extremely low bicarb levels and have a chronic metabolic acidosis.
So it's something we just need to kind of
something
be
you might want to
aware of
think
when
about.
we're testing.
Yeah. If you think someone's using a lot, then that might be something to think of in the back of your mind. There is no doubt, it's taken a little while for the evidence to come together, but there is no doubt that, like with alcohol, there is a solvent user's encephalopathy, a chronic encephalopathy that can probably cause long-term neurological injury in young people who use volatile substances, hydrocarbons. So a lot of work's been done in North America around looking at the MRIs of these people, and they can get attenuation and changes in the deep white matter. There's certainly, we've documented PET scan changes in people. There's very compelling animal evidence of blunting of serotonergic neurotransmission, and it's becoming apparent that they can get chronic neuropsychiatric and cognitive impairment from chronic toluene abuse and hydrocarbon abuse.
A lot of the teenagers, of course, mix agents, and you'll often see them and they will have taken some prescription drugs and probably some alcohol and maybe sniffed something. How do you sort out what's gone in and what to do for them?
Often it can be almost impossible to know exactly what they've taken, and knowing whether it's an amphetamine, a solvent, alcohol, some sedative hypnotics, benzodiazepines, some cannabis, some magic mushrooms, and any combination of permutations of the above, it can be very difficult to know exactly what's gone in. And we have to go right back to the basics. And my first thing is to say, how are we going with airway, breathing, circulation? Have we got any immediate threats to one of those basic things? So making sure that if they've got any evidence of altered cognition, is their airway okay? Breathing, assessing that, circulation, tachycardia, dysrhythmias, hypotension, any of those things. We need to check a temperature.
Yep.
If they've got any change to their cognition, it's always handy to check a blood sugar.
Yep.
Making sure we haven't got severe hyper or hypoglycemia. And there's a bit of a thing there that in emergency medicine, whenever there's altered cognition, it's always worth checking a blood sugar to make sure you're not missing occult hypoglycemia. Did I mention stopping seizures? And checking temperature as well, because people with psychoactive medication or with substance abuse, they can get hypo or hyperthermia, and we need to be able to detect and manage those.
Yep.
And hyperthermia in this setting is a bad prognostic indicator, so it needs to be detected and controlled.
Okay, now you've mentioned two things there that you've said to control. One of them is seizures. What's your best agent for controlling seizures in this sort of situation?
Benzodiazepines, undoubtedly, and you don't really need to get into too much of a esoteric argument about which one, how much, by which route. But benzodiazepines are always first line in the agent and the dose that you're comfortable with, that's age appropriate.
Yep.
And the vast majority of toxicological agents that cause seizures respond readily to benzodiazepines. There are second and third line agents such as using barbiturates and even sometimes pyridoxine, but the most important thing is benzodiazepines. Interestingly, we don't use phenytoin for seizures that we think might be related to toxicological agents. It's not been shown to be very effective, and in some situations it might even make things worse. So phenytoin we don't use.
And I can't imagine that there are a lot of barbiturates in very small country emergency departments to play with anyway.
The good news is that benzodiazepines in the vast majority of situations manage things very, very well.
Yeah. Now the other thing you mentioned was hypothermia. Do you just treat that by cooling?
The management of mild degrees of hypothermia, sort of up to 38.5 degrees, is just general and supportive. So if you've got a patient who's got psychomotor acceleration and is going and speeding and moving a lot, it would be reassuring, managing in a quiet environment, giving benzodiazepines maybe for some very gentle sedation and fluid replacement. If you've got somebody who's got temperature greater than 38.5, that becomes a more urgent resuscitative priority, and that might actually require more active cooling, more active resuscitation with fluids, and maybe even intubation and paralysis. 38.5 is the sort of the watershed. The former, lower levels, supportive care. The latter, you probably need advice if you're not sort of so.
Yeah, so I'm thinking maybe you've got a patient who's got a temperature of 39 and who's come in confused and kind of going, and you don't have any really clear history. How would you tell that this wasn't something that was an infective process rather than a drug-related process?
It can be quite difficult, and as we sort of talked about before, sometimes you need to take a history concurrent to your resuscitative manoeuvres and doing things. And that patient who's confused and combative and has a very high temperature, that sort of person, young person, yeah, you've got a broad differential diagnosis. They might be just postictal, they might have a central nervous system infection, they might have trauma even sometimes or a secondary process, and they might be a pure drug ingestion. Go back to the beginning and the basics, airway, breathing and circulation, resuscitation. You might actually have to intubate that patient paralyse them, and treat them with antibiotics empirically until things become clearer.
Now, of course, it's not just troubled teens getting into inappropriate overdoses, and there are an awful lot of depressed patients out there who can take enormous doses of various agents with very dinkum attempts to kill themselves. Can you just remind us of some of the management tips that we might need for those?
Certainly. Look, there's 6 million things that can poison you, almost literally, and it's unrealistic for everyone to really understand the nuances and the intricacies of managing each one of those things. It's fantastic to have a robust approach to poisoning that you can fall back to when you're dealing with a sick patient or a patient you're unfamiliar with, or they've taken an overdose. Fall back to that approach, and if you stick to the approach, you probably won't make any major errors, and you'll do the great thing for the patient. And that approach is to first take care of all the resuscitative priorities, and we've dealt with those a little bit. Airway, breathing, circulation, stop seizures, check a temperature.
Check the sugar.
Check the sugar, exactly.
IV access.
Yep, IV access, those sort of basic things. Do a 12-lead ECG, and maybe consider some screening tests like a serum paracetamol level if you've got access to it, things like that. The next step is to cognitively at least pause and perform a risk assessment. And the risk assessment is a distinct cognitive process where you're going to think about what you think's going on and then make some distinct decisions about all the management thereafter that's tailored to that patient based on your risk assessment. So rather than, oh, I'm just going to wait and see, or I'm going to throw in some charcoal and just hope for the best, get as best a history you can and take into account the agent, the dose, the time since ingestion, and therefore the clinical course that you're expecting to see given the agent and the dose, how the patient looks clinically right then in front of you, and making sure that they actually corroborates what you think is going on. And then finally, some patient-specific factors, like what's the patient's weight, what's the comorbidities and things like that. And taking into account the agents and the doses, you can probably develop a fairly good idea of what you think is going to happen and when. And if you like, calling the poison centre or talking to an expert on poisoning, the key part of that is getting a good risk assessment. And then after you've done that, again, in 85% of cases, you can feel pretty comfortable that some good supportive care is going to win through and everything's going to be fine. But in a small proportion of patients, you might say, we might need to do some tailored management, which might include things like gastrointestinal decontamination or skin decontamination. It might include doing some further investigations, specifically to find out whether the patient's got some target organ effects or whether they need antidotes. Or it might include enhanced elimination, dialysis or something sophisticated like that.
Even just extra saline so the diaries.
Something like that. Or finally, making some distinct decisions about what kind of observation they need and where. So whether you're comfortable doing that where you are in a regional centre, whether you're comfortable for parents to do that at home, or whether in fact you need to transfer this patient relatively urgently to a tertiary centre where they can get some more expert observation or definitive care. But that all comes from the risk assessment.
And you mentioned antidotes. What sort of antidotes do most country emergency departments carry?
In a resuscitation setting, almost every emergency department will have things like naloxone, bicarbonate, and we almost put benzodiazepines into that group as things that can be handy in a resuscitation situation. Paracetamol is still a common and almost ubiquitous poisoning. It's very rare that we would need to treat a child with an accidental poisoning with NAC, N-acetylcysteine, but adult poisoning we might need to treat, and most regional emergency departments will have NAC. More sophisticated antidotes like Digibind for digoxin and the chelating agents and things like that are more the reserve of a sort of a tertiary centre.
If somebody's taken I remember patients having taken overdoses sort of several days before and then woken up from their alcoholic stupor and decided they didn't want to die and come in with quite deranged liver function tests from their paracetamol overdose. Can the RFDS still fly in an antidote when they come to pick the patient up?
Absolutely. Yeah, and often the better thing to do logistically is take the antidote to the patient rather than the other way around, and of course you ensure that you get it a few hours earlier as well. Yeah.
Frank, earlier this year we had a little look at the safe handling of agricultural chemicals. Could you remind us about some of the effects of common ag chemicals that patients are exposed to?
The organophosphates are the ones that clinically we probably get the most exposure to, excuse the pun.
Yep.
They're rapidly absorbed, so if you ingest them, it causes rapid onset of life-threatening poisoning. And we sometimes see exposures from skin exposure as well, which are enough to cause symptoms. Usually the dermatological exposure is called relatively mild poisoning, but some people don't protect themselves at all and work with it all day and actually can get significant poisoning. The classic acronym for the symptoms of organophosphate poisoning is dumbbells, which if I can remember off the top of my head is the diarrhea, the urinary incontinence, meiosis in the eyes, B for bronchorrhea and bronchospasm, E for emesis, and L for lacrimation. But essentially you get wet from your parasympathetic nervous system being stimulated, and you die of respiratory failure. What dumbbells doesn't say though is that you also get CNS, with severe poisoning you can get CNS depression, central respiratory depression, and seizures, and cardiovascular instability as well. So it's a nasty poisoning. And again, if you have a sick patient, you go back to airway, breathing, circulation, and the key antidotes to use are atropine and pralidoxine. Although there is still lots of research going on in terms of the optimal use of antidotes in organophosphate poisoning.
Are there any other ag chemicals that you see coming through perhaps less commonly?
We see organochlorines, which are used to kill insects. We sometimes see the phosphides, the aluminium phosphides and things like that, which is very significant poisoning, although very rare. And we see herbicide exposures quite a lot as well. And there's a wide range of herbicides. Most of them, if you inhale a little bit or you get it on your skin, they're relatively non-toxic, and we only really see problems with the ingestion. Unfortunately, there's still one herbicide out there which is highly lethal, and for which there's not a great treatment, and that's paraquat. So with a concentrated solution, even 20 or 30 mils can be potentially lethal. And it's a nasty way to die. So any paraquat dose in terms of an oral dose is something that needs rapid referral and action.
Now, say somebody had taken some paraquat or something similarly toxic, are the doctors and resus staff who are treating them going to need to take any special precautions? Do they get some exposure from, say, trying to intubate the patient?
It's been very, very controversial, especially with organophosphates, about whether you can get, if you like, nosocomial poisoning from the patient. There is a potential for staff to get very mild effects from exposure to their fluids. However, hopefully you'd obviate that by universal precautions or standard precautions anyway. So certainly gloves and mask and gown, just to prevent you getting vomit on you or people coughing on you. There is, however, with organophosphates a very, very strong smell, and people are concerned that they might get poisoning from that. That is actually not the smell of the organophosphate itself. That's the smell of the hydrocarbon diluent, rather than
so what you're smelling is the solvent,
So you're smelling the solvent, and certainly if you're in an enclosed area, that can give staff a bit of a nasty headache and feel a bit unwell, but it's not going to give you organophosphate poisoning. And there's actually very, very little evidence in the peer-reviewed literature that staff can get significant poisoning if they use normal standard precautions. And we don't need for these patients to be using special space suits or calling a hazmat or managing them outside the emergency department.
Well, luckily in country emergency departments you can usually open the windows, which is helpful.
Yeah, and if they've got emesis on them or chemical still on them, it's actually important for the patient's sake to get that, to wash that off them at some point soon anyway, to reduce the absorption.
Yeah. Now, speaking of fumings, mining labs are another very common source of fumings. Could you go through the general process of assessing and treating somebody who comes in from, say, a mine assay lab, short of breath and irritated, and who says, "I've been fumed"? It's
really great if you can to get some information about what they've been exposed to. But let's just go back to the first principles, and the first thing is it's great to have actually removed them from the environment. Most of those kind of mucosal irritant exposures or problems with fuming occur because they've been working in an enclosed space, and often they haven't been using great occupational health and safety protocols with their fume hoods and things like that. So getting them out of the environment is the first most important thing. As a general rule, with things that cause mucosal or pulmonary irritation, the inflammatory response that you can get, the general inflammatory response, can sometimes take several hours to get to its worst extent. So it's important to take a good history and to see if the patient's got any evidence of cough, dyspnea, chest pain, and to look at them and ask yourself, are they coughing? Are they breathing a bit fast? Do they have any evidence of wheeze or crepitations in the chest? If they're completely well at 6 hours after their exposure, with no residual signs or symptoms, and normal physiological parameters, then it's safe probably to discharge the patient without a chest x-ray and say, look, if you get any further symptoms, come back and see us. The corollary of that, though, is if a patient has got some evidence of pulmonary irritation that persists at that time point, around 6 hours, then it's probably worth observing them to make sure they don't get a worsening inflammatory response.
And are you mostly looking at bronchospasm or are you mostly looking at pulmonary edema?
It's a little bit of both, and they can be coexistent. Some patients can get quite a severe, if you like, ARDS kind of syndrome without much wheeze. Other patients can get a bronchospastic response. If you hear wheeze, you can certainly treat it symptomatically with some beta-2 agonists. But the presence or absence of wheeze on its own is not necessarily a great prognostic indicator.
And how would you treat them otherwise?
It's supportive care. There's not much evidence that early steroids play much of a role. There's not much evidence that early antibiotics, even if they do have a low-grade fever, have much of a role. And certainly if they've got wheeze, you can treat it. But it's mainly supportive care. A very, very, very small minority of patients might need oxygen supplementation and maybe even some sort of supportive ventilation, non-invasive ventilation, or even intubation occasionally. But the main thing is to have those patients in the right place if they need it.
What about cyanide? I remember we always had a cyanide kit with this one vial of very beautiful purple stuff that, thank God, I never had to use. What happens if someone's exposed to cyanide in a gold lab?
Cyanide, intentional cyanide ingestions are often fatal. And if they're in a remote area and they've properly taken some cyanide, they'll probably die. And if they get to hospital and you've got some cyanide antidotes, which we'll talk about in a minute, then you might be lucky, but they frequently die pre-hospital. If there's a gaseous exposure to cyanide, the key, most important step is to get them into a ventilated area. And in fact, even if someone collapses or feels very unwell, if you get them into fresh air rapidly, often that's all you need to do. And they'll have a great outcome just by getting them oxygen or getting them into fresh air. The body has quite an efficient cyanide detoxification process and will take care of itself. Having said that, if you've got somebody who's borderline and they've collapsed, lost consciousness, had a seizure, or they've got cardiac instability, then there are a number of cyanide antidotes. We used to use a lot of thiosulfate and a cyanide antidote kit.
Yep.
Hydroxycobalamin is probably the most efficacious and the safest antidote, but it's not got TGA approval. Having said that,
That's B12.
B12,
Yeah.
or the precursor, but many mine sites do have it on site, and it's a safe antidote for cyanide. The bottom line though is get people out into fresh air, but if they are unstable, airway, breathing, circulation are your key things to do, and then after that, if you've taken care of those things, you'll actually ensure the survival of most of those people. And if you're still going beyond that point, then there can be a discussion about antidotes.
And after the Esperance lead experience over the past couple of years, could you comment on assessing or maybe detecting chronic lead exposure?
Yeah, look, the two major settings where lead is a concern in Australia are chronic accidental paediatric exposure, which is really the Esperance setting, and then more rarely occupational exposure in certain industries. In fact, most of the time we see lead now in workers is people working in almost sort of cottage industries or in hobbies at home, where they're doing lead smelting, or they're they're melting
Soldering
down lead,
something.
or they're soldering, or they're doing lead work with glass, or they're doing some restoration of railings, or doing something at home with lead. 2 or 3 decades ago, it was recognised that exposure to young brains by lead could cause some problems with neurological development. And a decade ago, we thought that 10 micrograms per decilitre was about the threshold where you might get some detectable problems with neurological development, but not in individuals, in populations.
Yeah.
It's actually very difficult to take a kid with a given lead level of, say, 12, 15 or 25 and actually later identify whether or not their potential to develop an IQ has been blunted by a quarter of an IQ point. But when you look to paediatric populations of children across a whole community and you expose them to lead, then you see maybe deleterious effects. So that's the thing about assessing a population versus an individual. We've now recognised in the last decade or so that in fact the dose response might be even lower. And so ideally we'd like to have the lowest possible lead levels. Having said that, all of us who live in urban areas are exposed to airborne lead. And we all will have a level that's detectable of 2 or maybe even 3 micrograms per decilitre.
Yep.
And it's really almost impossible with current technology to detect whether that's going to have a deleterious effect on our population, and certainly you're not going to be able to see a difference in a kid. If you suspect that a child might be exposed to lead and you do a lead level and it's a little bit elevated, the most important thing is that represents an index case. So it might be worth checking other kids in the area or in the family. And the second most important thing is to try and then diminish the exposure. Because at this stage, there's no therapy per se that's going to prevent the injury or ameliorate the injury. So the most important thing is to find out how the child's being exposed to lead and reduce that.
Now, if you took the child out of that environment, say sent them to boarding school or something, just for argument's sake, their levels will fall.
Yep.
Does that completely ameliorate the effects, or does it just stop any further effects from happening?
Well, we're not entirely sure about that, but it should prevent any further injury occurring and allow subsequently normal neurological development.
Yep.
But remember, the effects of lead, low dose lead, on neurodevelopment are very, very subtle and can only really be detected at population level.
Yep. We do hear an awful lot about snakebite and snakebite treatment, Frank, but there's loads of other nasties in the Australian outback. What other bites, stings and scratches come into your emergency department?
Redback envenoming is ubiquitous around Australia,
Yep.
and we see that quite a lot. And in fact, we're coming back to redback season, at least in the southern states at the moment.
We sure are.
So we're coming up to that.
Now that freaks the patients out and they all think they're going to die, but
They
of course
know.
this is not the case.
That's the first thing. It's really important to emphasise to patients that people don't die of redback envenoming. And in fact, most patients who are bitten don't get more than local effects. And many patients can be treated just with normal analgesia.
Yep.
And that's really, really encouraging. I've been bitten twice and never needed antivenom. So that's a good thing. However, some patients do get really refractory local pain, or they get more of the systemic envenoming, more distal pain, so pain up the arm, pain in their pelvis, pain in their abdomen, chest, headache, things like that. Or they get sweaty in funny locations. People often get bitten on one leg but sweat on both legs. Or they just get generally very dysphoric and almost sort of like renal colic.
Yep.
The jury is still out on how efficacious redback antivenom is, and we're still doing randomised control studies on the use of antivenom. But certainly if a patient has refractory symptoms to the normal Panadol, Panadine, then we might consider antivenom. But it's really important to reassure people that just because they've been bitten, they don't need to run to the hospital. And they'll probably, 75% of patients will probably be fine with some Panadol.
Yep. Cold pack?
Certainly, yep. But not pressure immobilisation.
No.
No.
And my recall of redback spider bite was if you did need to give antivenom, 1 bite, 1 ampule?
1 or 2 ampules, and again, we're still studying that. We did for a while treat refractory symptoms with more and more antivenom. We're now no longer sure whether that actually makes sense and whether it makes any difference. But yep, certainly antivenom is still an option.
What's the latest on jellyfish and vinegar?
Vinegar for blue bottle type Physalia kind of stings around the southern coastlines. Vinegar does seem to decrease the nematocyst firing. And if you've got it on hand, vinegar can still be used. There was a fantastic randomised control study done a few years ago in Newcastle that showed that hot water, hot showers, is very good for the pain of jellyfish stings as well. So there was a debate for a while about vinegar versus cold water versus hot water, but the randomised control study showed that hot water at around the temperature that is just starting to feel a bit too hot, sort of around 40 degrees Celsius, is very good for the sting of jellyfish.
Yeah. How do you get the stings off?
There used to be a old wives' tale that you would rub it with sand or rub them off. That will just make, the pressure will make the nematocysts fire more. So just very carefully peel them off to minimise the agitation. And
for our beach-going lovers in the northern part of the state, I guess the stonefish and the blue-ringed octopuses, octopi, are coming out in force at this season as well. What should they be aware of? Blue-ringed octopus first, they're actually all around the coast, right around Australia, and they cause paralysis. And the main thing with blue-ringed octopus is just don't touch them, or octopi. Don't touch them. Don't let them bite you. If they do bite you, they cause a rapid onset of paralysis, and that's purely supportive care. So you just keep ventilating the patient until the venom bleeds off? And they will get better, usually within 24 hours. Okay, that's a long time to be doing CPR. It's a long time, but you just do expired air resuscitation until you get... So their heart will keep beating, and you've just got to keep that air going through. And they'll be awake, although paralysed. So reassure them and keep ventilating them, and they'll be fine. We're very lucky. I think most people know that you don't play with blue-ringed octopi, and there hasn't been a really significant envenoming in Australia for a number of years, which is good. However, if somebody came in, I guess it would be important to remember that they are awake, so that if you do decide to intubate them, it would be kind to give them some midazolam or something. They'll be aware if they're oxygenated, that's right. They'll be aware. Stonefish, or any of the spines fish for that matter, cause a very, very painful sting. And the two issues with stonefish are primarily analgesia, and you can use opiates, which often they're quite resistant to,
or you can use local anaesthetic techniques, and you can use hot water.
So put in a whole regional block, you said, when
Yeah,
with
you could
the
put in
anaesthetic?
you could put a foot block in, or some sort of regional block on the hand if you wanted to. You can use hot water. Hot water seems to diminish the pain of the spine fish envenomings. The most important thing there is you're going to use very hot water in a bucket to put your foot in. Put the other one in the hot water as well, so you don't get a burn. Because people will actually put their foot with a stonefish sting into hot water that will actually burn them and not realise them. So you put both feet in to prevent that problem. If you've got a stonefish envenoming which is refractory to those kind of measures, then you can consider antivenom as well.
And there is such a thing?
Yes, there is stonefish antivenom, and it appears to be very, very effective. And so in the northern parts of Australia, there are lots of people in coastal areas that are familiar with using the antivenom.
While we're thinking about various nasty critters, a lot of patients are particularly worried about white-tailed spider bite. And I've seen necrotising reactions to a number of different critter bites, so I'm not so sure that the white-tailed spider is the culprit. But have you got any good tips on when somebody comes in with really what looks like a very mushy ulcer?
Yeah, look, Lampona cylindrata, that poor spider, the white-tailed spider bite, is ubiquitous around Australia. Again, it's a spider that we have in most of our homes. And Jeff Ispister in the eastern states did some really good research about 5 years ago now that really debunked the myth that that particular spider was responsible for a syndrome of necrotising arachnidism, where you get a nasty non-healing ulcer related to a spider bite. There are spiders in the world, the Loxosceles genus, which do cause that syndrome, but we're very lucky in Australia that we don't have those. Having said that, it's not an uncommon inquiry when I've got a patient, they think they might have been bitten by a spider and they've got an ulcer somewhere. The first thing is to keep an open mind. There are spiders and even ant bites that might cause superficial sloughing reactions or cause some prolonged redness or pain after a bite. And the best thing to do that is to reassure people and just keep an eye on things and make sure there's no secondary infection or anything like that. However, if you've got a really indolent ulcer that is not healing, it's probably important to get a biopsy. There is a tendency to blame a spider and go down that track. But in fact, there's a very broad differential diagnosis that includes a number of things that you can treat and are not related to spiders or any bites at all. And I think that the good principle is if you've got an ulcer that you don't know the exact cause, to get a biopsy and a referral so that you can actually get on the right track.
Fabulous. Frank, do you have any take-home messages for the doctors?
We'd be delighted to hear from people who need help to make a risk assessment. The Poison Centre is there as a 24-hour-a-day resource, and you can get some basic risk assessment advice, but you can also speak to a clinical toxicologist 24 hours a day.
Frank, thanks very much for coming on the program today.
Absolute pleasure, thank you.
Well, that's all we have time for in this program, and a big thank you to all our guests for taking the time to talk with us. Now, if you're interested in finding out more about this particular topic, the Volatile Substance Use Guidelines by the National Health and Medical Research Council have been developed and are in the final stages of being drafted. The guidelines will be available on the National Health and Medical Research Council Clinical Guidelines portal, which is clinicalguidelines.gov.au, and they'll be up in the very near future. Now, we'll be back next year on the 7th of February with a program which focuses on dental health. And remember, you can view all of our programs at the Rural Health West website, ruralhealthwest.com.au. On behalf of all of the staff here at Rural Health West, thanks for joining us this year, and we look forward to bringing you another year of programs in 2012. Until then, have a fantastic Christmas and a great new year.